Good morning, everyone, and welcome to this symposium, The Illusion of Remission. My name is Tim Rain. I'm a gastroenterologist from Cambridge in the United Kingdom, and it's my absolute pleasure to welcome you to this symposium. The name of this symposium is deliberately crafted to conjure up an air of mystery. And it's an air of mystery that I hope in the course of the next hour we can start to unravel for you as we realize that all is not quite what it seems when we come to think about the drugs that we perhaps most commonly use in the management of IBD, namely corticosteroids. It's my absolute delight to be joined today by some absolutely stellar faculty. Professor Dotan needs absolutely no introduction, coming from Tel Aviv in Israel. And likewise, Professor Mark Silverberg from Toronto in Canada. I'm delighted to be joined by you both, and we very much look forward to your contributions. Between the three of us, we're going to take you through a journey. And the journey begins really with looking back at the history of how we've used steroids and really what we currently know about contemporary practice. Iris is going to take us on to look at maybe some of the hidden burden that we're not even conscious of, the unknown unknowns in our management of IBD. Before Mark casts an eye to the future and asks the way that we'll be using steroids, both in future practice, but also in the context of future clinical trials. And then hopefully we'll have some time for your questions. The Asking Questions of this symposium is based upon question cards. You should all have one in front of you that you were given on the way in. Please, please, please do use it. We don't have the opportunity to take questions via the Congress app, so please use the question card to write your questions on, hand them to one of the members of staff around. They'll bring them up onto stage, and we'll look forward to answering those. There is also an evaluation form. You'll notice it has a pre and post evaluation. If you could just take a moment now to look at the pre section and fill that in, and then at the end we'll ask you again to complete the post-Congress evaluation. You'll also be given a scratch card. No prizes for winning this one, but hopefully something to have a little bit of fun with and look through and see the way that uncovering maybe hidden information around the use of steroids can shape your own clinical decision making. And finally, there will be the opportunity to take part in interactive voting. You should all have a voting keypad, which should have been given on the way in. And in case I forget to mention it at the end, please do hand it to a member of staff at the end of the symposium. So with all that said, let's have a test of the voting keypads now. February the 14th, just 3 days away, 2 days away. Or is it tomorrow?
Tomorrow.
It's tomorrow. I've not bought a card yet.
We know your answer now.
Yes, thank you for reminding me of that. So, will you be giving anyone a Valentine's card? 1 for yes, 2 for no, 3, it's a secret, or 4, only to myself. So let's test the voting now. I can see you're voting, the votes are flooding in. Let's keep the polling open just a little while longer. 7 seconds left to vote. Still voting. Oh, what an unromantic lot you are. Okay. So, when we think about corticosteroids, it's worth reminding ourselves that these were indeed the first drugs to really undergo proper therapeutic testing in inflammatory bowel disease in the form of this absolutely seminal randomized controlled trial from Sidney Truelove and Leslie Witt in Oxford in the 1950s, a trial that was so advanced that the first paragraph of the text had to be spent explaining to readers just what a randomized controlled placebo trial was. And of course, this established these treatments as tremendously effective induction therapies for patients with active ulcerative colitis. It took a further 20 years to establish the same data for Crohn's disease in the context of a large North American and European study. But we should reflect upon the fact that these treatments are a firefighting tool. They are tremendously effective at putting out fires, but they are not a fire prevention strategy. Furthermore, there are a number of limitations to what we can currently achieve with corticosteroid therapy. And I don't want to steal any of Iris and Mark's thunder, but I'll just whet your appetite by telling you that they're going to tell you a little bit about how imperfect the outcomes can be from corticosteroid therapy. The fact that these therapies are not in any way effective maintenance treatments, although all too often they are used precisely as such. and furthermore, actually, that these drugs do little, if anything, to induce mucosal healing. But actually, what I want to tell you about is that these drugs have side effects. Well, you know that already, but maybe we don't appreciate just what the full range of side effects are. These are the only drugs in the history of IBD that have ever actually been shown to confer excess mortality, as we see from this very large registry comprising 15,000 years of patient experience in the TREAT registry. And for this reason, as well as the panoply of other side effects associated with corticosteroids, many professional bodies have recommended that we should try, where possible, to avoid using them. So our American colleagues say that we should use corticosteroids sparingly in Crohn's disease and take care to try and discontinue them. For Crohn's and in ulcerative colitis, again, the goal should be to obtain and maintain steroid-free remission. In Europe, we're a little more granular around our definitions. So the Crohn's guidelines from ECHO state that we should try at all costs to get patients off corticosteroids and really define dependency or excess on the basis of an inability to wean patients below 10 milligrams of prednisolone a day or 3 milligrams of budesonide within 3 months of starting that treatment. Or alternatively, corticosteroid dependency in patients who are relapsing within 3 months of stopping steroids or who are requiring more than a single course of corticosteroids in a year. It's not just professional societies who have recognized the importance of this. This is a paper from a patient organization in the UK, Crohn's and Colitis UK. And our patient body has identified corticosteroid-free remission as a key step on the ideal patient journey with inflammatory bowel disease. Likewise, in this Danish study, when patients were asked to identify what mattered to them most around the therapies that they might be exposed to for their inflammatory bowel disease, the most important factor that patients identified was efficacy. They wanted a medicine that was going to provide them with significant, relatively early improvement. But the next most important factor was the fact that a medication would reduce or completely avoid their need to take corticosteroids. And yet, despite all of this, we still know that these drugs are very widely used. So this is a study from Corey Siegel looking at over 16,000 patients in the United States and their journeys with Crohn's disease in this instance. And what you'll see is that corticosteroids are not just heavily used up front, but repeatedly used in the management of patients with Crohn's disease. Indeed, if we look at secular trends, we have these data coming from Canada, effectively showing that really we continue to use these drugs as much now as we ever have done, if anything, possibly with a slightly increasing tendency over time, despite the availability of corticosteroid-sparing strategies. Now, is that because steroids are cheap? Well, undeniably they are. But this is a very interesting healthcare claims database study that looks at the excess costs of treatment care for patients with ulcerative colitis and Crohn's. Now, these figures do not include the cost of therapy. So this is just the additional cost of looking after patients. And what you'll see is that patients managed with oral corticosteroids with both Crohn's and UC incur significant excess treatment costs compared to those patients managed with either immunosuppressants or anti-TNF therapy. In the UK, we started looking at this by developing a steroid assessment tool that enabled us to audit our practice across many centers in the United Kingdom. And this was a simple, powerful tool that we designed for rollout in routine clinical practice. In fact, we captured data initially on almost 1,200 UK patients with inflammatory bowel disease and found that 30% of them had had some form of steroid exposure within the previous 12 months. But actually, if we drill down a little deeper into that, we discovered that around 15% of these patients had had excess corticosteroid exposure within the previous 12 months. And actually, if we were looking for a risk group that was most at risk of either corticosteroid exposure or corticosteroid excess, it was patients with moderate to severe ulcerative colitis. Similar data have come from pediatric studies, this cohort from our colleagues in Glasgow, who demonstrated again, even in a population where we really want to avoid corticosteroid exposure, significant corticosteroid exposure and dependency in children with moderate to severe ulcerative colitis. Now, we repeated that 2 years later and saw that the rates of corticosteroid exposure were relatively constant across the whole of the UK over time. But interestingly, when we looked specifically at those centers that had embedded the audit within their practice, what we found was trends towards less corticosteroid excess and indeed statistically lower corticosteroid exposure in these patients. The simple act of auditing appeared to be associated with a reduced use of these drugs. So which patients, other than those with moderate severe UC, are most likely to get corticosteroid excess? Well, here we have data for Crohn's disease, and we can see that at multivariable level, the use of anti-TNF appears to be protective against corticosteroid excess. The management of patients in centers with an active multidisciplinary team was also protective. As I've just told you, participation in a steroid audit appeared to be an independently associated variable with reduced corticosteroid excess. And likewise, patients managed on thiopurine monotherapy had a slight increase in their risk of corticosteroid exposure. And for UC, we have relatively similar data. Now, in the UK, this has led to a number of steps at multiple different levels. So at a patient level, our patient charity has produced an information leaflet about corticosteroids, highlighting to patients the importance of these therapies, but also their limitation. Our Royal College of General Practitioners has produced a toolkit aimed to increase the skills of our general practitioners in the management of IBD, and one of the key components of this toolkit is the need to liaise with secondary care whenever considering corticosteroid initiation. And in secondary care, we've introduced a new series of standards which govern what we think a well-managed IBD service should look like, and key to those standards is the need to regularly audit and monitor steroid usage. So in summary, yes, we have guidelines that recommend the use of corticosteroid-sparing treatments, and yet these treatments continue to be used at high frequency despite our patients' clear preference to avoid them. The most at-risk group appear to be patients with moderate to severe ulcerative colitis, and the simple act of asking the question of yourself, how much steroid am I using in my practice, does appear to be associated with an overall reduction in corticosteroid exposure and corticosteroid excess.